Hello, good morning everybody, and welcome to our October Clinical Risk Forum webinar. It's very good to see you all virtually on here today. We've got a great lineup of speakers across our clinical law teams. So we have Charlotte Miller, who is an associate in our clinical claims team, talking to you about potential for COVID-related cancer claims. That's something that we touched upon at our last clinical risk forum, and Charlotte's going to be looking at that in a little bit more detail today, and also looking at phase 3 of NHS England's plan and the potential for a COVID-related public inquiry in the future, and what sort of things we might expect to see from that. We're then joined by Ian Cooper from our advisory team, who's going to be talking to us today about CQC and an update on enforcement. And Georgia Ford from the inquest team will be doing a quick roundup of all of the latest inquest news covering the south of England. So we've got quite a lot going on today. The good news is that this webinar is being recorded, so we will be sharing the link with you later. So anything that you want to re-watch, you're welcome to do that, and you can also share the link with any colleagues who you think might be interested in the content. Hopefully there won't be any technical issues today and all will run smoothly. If you do have any problems, there is a chat box and you can put a message in there around any technical issues, and we do have people in the background who will be able to help you with that. At the end of the session, we will have time for a bit of Q&A. So there is a Q&A box which you can access depending what device you're on. It's either at the top or at the bottom of your screen. There's a little Q&A tab. So any questions that you've got as the talks go on, do feel free to type them in there and we will pick them up and speak about those at the end of the session. You can like other people's questions as well to push them to the top of the list, so do look out for other people's questions, and if it's things that you would also be interested to hear the answer to, you can like those and we'll make sure that we respond. Finally, there will be a feedback form coming round at the end of this seminar, so do fill that in and send it back. It really helps us to know what sort of things you're interested in, how you found the content, and so that we can plan for future events. So look out for that, which will be coming through along with the link to the recorded version of the webinar at the end. So without further ado, I will hand over to Charlotte for our first section. Thanks, Charlotte.
Great, thanks, Rebecca. Good morning, everyone. Thank you very much for joining us. I wish I could see you all face to face, but hopefully we'll be able to do that sooner rather than later. So there's going to be 3 things that I'm going to cover today. As Rebecca mentioned, I'm going to run through what we're anticipating in terms of some potential cancer-related COVID claims. We'll then look briefly at phase 3 of NHS England's response, and then I'll cover what we're anticipating in terms of a public inquiry. So the first thing that I thought I would do this morning was just to recap some of the numbers in terms of where we are at the moment in terms of the non-COVID patient treatment. I think some of you will have seen some of this data potentially from our previous webinar, but it just sets the scene quite nicely in terms of why we're anticipating there to be some claims, particularly in relation to cancer. So we know that more than 2 million people have been waiting longer than 18 weeks for routine operations. Sadly, with 83,000 waiting more than a year. The Royal College of Surgeons has recently surveyed some of their members in September, and they found that only 14% were able to treat the same number of patients as they had done prior to the pandemic. We also know that at the peak of the pandemic, there were more than twice as many people dying compared to the base rates. And then interestingly, the statistics around A&E attendances are that actually it was the younger generations who weren't attending A&E in the same levels. And in fact, up to age 19, attendances were down by as much as 65%. And then crucially, in terms of for our purposes this morning, the estimates that we have are that there will be a cancer backlog of up to 80,000 patients with a predicted 35,000 avoidable deaths. So before we look into what's happening sort of post the peak pandemic earlier in this year in terms of cancer, I just thought it would be useful to recap what I'm sure most of you already know in terms of what the targets were pre-COVID. So from your GP referral, there was of course the 14-day target time to then be seen by the specialist. There would then be the MDT review or the decision about the clinical pathway for your treatment. And then from the decision for treatment, there was then another target time of 31 days for that first treatment to take place. So of course, we know that these cancer target times are very important. And one of the main reasons for that, which of course will feed into why we're anticipating there to be a lot of claims, is that timing in terms of your cancer diagnosis and treatment is really crucial. And generally speaking, it's anticipated that the earlier a cancer is caught and treated, the better chances you have of a good outcome. So if that's what the target was and what we were aiming for previously, where are we now? So at the start of the pandemic in March 2020, cancer screening, so that's things like your bowel cancer, your breast cancer and cervical smears, were all suspended. And there was deferral of routine diagnostics and outpatients. NICE, of course, issued some guidance in relation to cancer care, and that referred to the need to both delay and avoid cancer treatment. As was the case with many specialties, we also know that cancer doctors were put onto these mega rotas, as I believe they were called, and redeployed out of their specialist area to assist with the COVID patients. Of course, although that ended in July, I think in the news recently, there's been a lot about staff potentially being called back and being redeployed once again. So one of the reasons that that approach was taken might have been that initially the data that was coming in from China was that cancer patients did a lot worse if they contracted COVID-19 compared to others. Now that might not be that surprising, given we know that most cancer treatment or a lot of cancer treatments might lead you to be immunosuppressed, so there'd be a particular concern to protect those patients. And then finally, of course, also there might be some patients who are symptomatic at home, but because of fears of COVID and or not wanting to burden the NHS, simply haven't come forward to seek medical treatment. So then the key sort of point at the bottom of that slide you'll see is that the data suggests that at the peak of the pandemic earlier in the year, their referrals for cancer were down by as much as 80%. So we can see there's clearly going to be a lot of patients that have been affected by the pandemic and by the changes in the cancer care pathways. So what we might be looking at. So when we're thinking about claims coming in, and a lot of you on this webinar, if you work in the legal department, departments of your trusts, you might be seeing things landing on your desk, requests for disclosure, or even letters of claim in due course. And there's certain sort of factual scenarios that we are expecting to see. So, for example, those patients who simply weren't captured through the screening programs. So like we mentioned earlier, bowel, breast cancer, cervical smears. Then those patients who perhaps weren't referred for testing or investigations during the pandemic. And I think you'll have seen in the news, there's various sort of patients saying that they went to their GP concerned and they were told they couldn't be referred for, say, scanning or other diagnostics. Then patients that are lost to follow-up. So perhaps there are patients that have already had their first line treatment and then were due to come back in to check for recurrence, etc. But unfortunately, those clinics or appointments were cancelled. What's happened to them? Then cancer substitute treatments. And I'm informed by some oncology experts that often they're not as good. So are we going to face patients who had some different, slightly, maybe unusual treatments, and that hasn't quite worked as well as, say, if they'd had chemotherapy? Then a failure to undertake treatment or surgery at all, perhaps specifically if they're aerosol generating, so there's particular concerns, and as well as things like chemotherapy, if there's concerns about immunosuppression. And then finally, again, something that I know that I've seen a lot in the media, are patients who say they had to go to their local private hospital, for example, an MRI, because it wasn't available on the NHS, and they now want to claim the cost of that back. So thinking about if they're the sorts of factual scenarios that we are anticipating, that means that generally speaking, we might see that patients or claimants looking to pursue a claim for cancer claims will fall into two tranches. The first are those who were in fact diagnosed with cancer before the COVID-19 pandemic hit, but because of the pressures and the new guidelines that were brought into place, they simply then didn't have the treatment, or they were lost to follow-up, etc. And then, of course, there's the group of patients who simply won't have been diagnosed when otherwise they would have been if it wasn't for the pandemic. So that's where we are. And part of the reason that we're anticipating this to be such a problem is simply because of the volume of these sorts of cases. So we know that 1 in 2 people get cancer at some point in their lifetime. And we know that very sadly, 1 in 3 people die of their cancer. And that generally speaking, there's 300,000 cases a year. So if that's a problem, what are we going to do moving forward? Some of the estimates that we've seen suggest that the NHS would need to increase its capacity by 135% to catch up in 6 months, and that it will take 5 years to get the NHS back to its pre-COVID functioning. So there's likely to still be a lot more to come in terms of these sorts of potential claims and problems. And of course, I'm sure we were all glued to the TV last night in terms of what's happening now with this further resurgence of the virus. And if there's a second wave, and again, services have to be stopped within the NHS to focus on COVID, this could all essentially become a lot worse. So just thinking about the claims and some tips for those of you who will be dealing with these sort of within the trust, and what you can be doing now to try and assist moving forward. The first thing I would say is to make sure that your departments are sort of very regularly reviewing their policies that are in place to ensure that non-COVID care is still prioritised where necessary, and of course is in accordance with national guidance. Secondly, and this won't come as a surprise, make sure that documentation is really up to scratch. So if patients are being told they cannot have certain referrals or treatments, etc., that's carefully documented in the notes as to what was explained to the patient, why that was the case, and perhaps what options there are moving forward. Then query whether it's possible to audit the success of things like your online appointments or new clinical pathways alongside the risk assessments that would have been done before those pathways changed. Going back to follow-up, it's then making sure we get in touch with patients who've had their appointments cancelled or postponed so that they aren't lost and that they do come back into the service when needed. And then finally, disclosure. I'm sure this is something that those of you on this call deal with quite regularly, but making sure that you're prepared for the sort of disclosure requests that might come in. So for example, policies that are relevant to new clinical pathways, and any changes that happened within the trust around the COVID time to evidence what was done and why. And I mean, all of this, it's important to bear in mind, which is what I'm going to come on to next, is that also since NHS England announced their stage 3 from August 2020, there might be additional pressure there from patients or potential claimants saying, well, look, from August 2020, NHS England told you that we should be getting back to normal if we can. So just that's something to bear in mind about, will there be a difference from August 2020? So then moving on into NHS England stage 3, clearly there is a pressure to get services restarted. And as I said, from August 2020, NHS England stage 3 report focused on the need to accelerate a return to near normal levels and referenced this window of opportunity before the winter pressures, as you would usually expect. Important for our discussion today is that stage 3 report really focused on the restoration of cancer services. So in particular, the report referred to the need to increase diagnostic capacity again, so increase scanning and use independent facilities where possible. It also specifically referred to making sure that things like endoscopies and colonoscopies started up again with extra safety precautions if needed for the aerosol generating procedures. And linking into what we discussed before about these patients and follow-up, there was a need for there to be an immediate plan put in place for those who had been waiting longer than 104 days. So none of that is easy, especially if we're going to move into a second wave. But for all the reasons that we've explored earlier, obviously it is crucial in terms of the non-COVID patient treatment. And I just thought I would quickly pause here and just sort of give an example of where NHS providers recently did a report and they looked at what the London Ambulance Service had done in terms of managing that additional COVID and non-COVID pressure at the peak of the pandemic earlier in the year. So just by way of example, the London Ambulance Service would normally expect 6,000 claims on a normal, 6,000 calls on a normal day. And on the 23rd of March, it peaked at nearly 11,500. So the report sets out that the London Ambulance Service, they brought in some specially trained student paramedics from partner universities to handle the call handling hub. They worked with the AA to get more vehicles on the road and to keep them there. And really interestingly, there was blue light collaboration as they trained 300 firefighters from the London Fire Brigade, who then were deployed out on the road with the London ambulance staff. So a positive note there. So if we then move on from individual claims and we look at the bigger picture, so we know that there's been some problems and challenges, of course, and what might emerge from that as part of an inquiry. So I'm sure you'll have seen in the news already, there's obviously lots of discussions about what inquiries need to happen. And we're of course anticipating there will be a wide-reaching public inquiry. At this stage, we don't know exactly what that will look like. It might be that there's particular aspects such as BAME concerns or PPE concerns, but certainly there will be a level of data and information that will need to be given to an inquiry from individual NHS organisations and some level of scrutiny. So if your organisation is asked to provide that information, or that's something that you'd like to start looking into now, of course, we here at CAPTIX can support you in doing that. So please do get in touch. But at the moment, the things that we would suggest are likely to be requested and the data that's going to be needed are set out on this slide. And just briefly running through that, some of the information I'm sure is already going to be held by the Trust, things like the number of patients that have died, the number of patients who contracted COVID whilst in the hospital setting, which type of appointments and operations were cancelled. For example, did dermatology take a big hit? Was it your orthopaedic surgery or your orthopaedic outpatients? And then in terms of things that went online, so if you changed pathways and you moved to video appointments or telephone appointments, what were the risks? How did that work? What was the uptake? You know, trying to identify and get ahead of these potential issues that might come out of the woodwork. And then in terms of wait lists, that will be really crucial. So how many patients are on your wait lists? Which wait lists are particularly long? Is it cancer, for example? And then a slightly different aspect that I suspect will be looked into is in fact the impact on staff. So again, it's been in the news about, you know, a second wave and just staff exhaustion. They've already pulled out all the stops once. What was the support like? And then of course also PPE, I'm sure will be looked into. So that's what we expect to come, and some of that information will be needed. But there are in fact already lots of investigations and inquiries underway. And actually, I'm sure you'll see these are changing in the news daily and things are regularly being announced. But just some examples to give a flavour. As we mentioned earlier, the Royal College of Surgeons are surveying their members regularly about the impact on elective surgery. The Health Foundation, the charity, has in fact already quite recently launched a COVID-19 impact inquiry, and they in particular want to focus on the health inequalities that have been exposed by the pandemic. For example, the much higher risk that there is to Black males and females compared to their counterparts. Also recently, Jeremy Hunt and Greg Clark announced they would do a cross-party investigation into the UK's handling. My understanding is the idea is that that will be, well, the hope is that that will come out much quicker than some of the other inquiries, and there'll be weekly meetings with people like Chris Whitty. There's then individual internal trust reviews, which I believe are very much encouraged in terms of, is there a particular outbreak that's happened in your hospital? Why was that? And then finally, again, it's been in the news recently, is that medical examiners are being asked to in particular, scrutinise and review the deaths of frontline workers where there is a concern that they have contracted the virus during their work. So that's a sort of flash run through of things that we're anticipating in terms of cancer claims, NHS England's new phase 3 and potential inquiries. And if there's anything in there that we can help you with or anything you'd like to discuss, then obviously please do get in contact. And I hope it's been useful. And I'll hand over to my colleagues now.
Thanks, Charlotte. So hello, everyone. I hope you're all well. My name is Ian Cooper. I'm a partner at Cap6, based in our Leeds office. I look after our advisory teams in Leeds, London and Birmingham. I also head up everything that we do for clients in CQC land. And that's what I want to talk to you about today, really is to talk about what the impact of COVID has been on the CQC's inspection and enforcement activity, and to share with you some trends that we've spotted. So first of all, I was going to talk about the emergency support framework. So if I can move on to the next slide. So on the 16th of March, when the pandemic hit, the CQC announced that all routine inspections would be stopped at that point, with a view to just basically to back off, to give providers the opportunity to deal with the pandemic that they were facing. And then they had to think, well, how are we actually going to discharge our duties to inspect and regulate providers of health and social care during this time? And how are we effectively going to regulate from a distance? So that led to them coming up with the emergency support framework and putting that in place. So from the 4th of May 2020, the emergency support framework effectively set out how the CQC was going to regulate providers of health and social care during the pandemic. And essentially they were choosing to adopt a risk-based approach. They accepted they can't exactly send coach loads full of inspectors onto hospital premises or care homes. Nobody wanted or needed that. So they were going to try and direct their resources to the areas which presented the most risk. And their obvious issue there is to how to work out where those risk areas are. How do they monitor something from a distance? So they really ramped up the amount of information sharing between the CQC and providers and moved to holding conversations with providers. And they held about 20,000 conversations with providers over the course of about 4 months, to touch base with providers, to ask them a series of questions, really focused on 4 areas in those conversations. So safe care and treatment, staffing, protection from abuse, so safeguarding, and the assurance processes and monitoring and risk management arrangements they had in place, in particular around infection prevention and control. So they had those conversations on MS Teams, as I understand it, going through those 4 areas of focus, lasting about an hour or less. So they said the result of those conversations was then a summary record of the conversation, which was just shared with the provider, nothing published at that point. Then the CQC had to work out, look, is this a provider that's managing, or do they need support? And also, if we've identified any risk issues, how do we go about investigating those risk issues further? So they still had the ability and still carried on the ability throughout the period of the emergency support framework to come on site and to inspect, but they held that back for those areas which they thought were particularly risky, or as a result of those conversations or that information sharing, they thought they'd identified risks that they as a regulator couldn't live with, and they had to get out there. And in some cases, they would go down an enforcement route. And I'll have a look later on at the sorts of enforcement activity that we've seen through this time. There have been inspection reports published during that time. And also running alongside the conversations and the exchange of information. If anybody stuck their hand up in an organisation and sort of had whistleblowing concerns, or if any red flags were seen, such as an increase in never events, they still had the ability to come on and carry out an inspection, but we didn't see very many of those inspections at all. So any inspection that did take place would have led to a report in the same way, but it wasn't a full Monty sort of 360-page report that you'd be used to seeing. It was a focused inspection report, focused just on those particular areas they were looking at. In terms of NHS trusts, the focus was very much on infection prevention and control, and they had a sort of set script that they would talk to trusts about. So they would ask, how is the board assuring itself about infection prevention and control, and how has the board got a grip on that? What are the governance arrangements? What are the risk assessment audit arrangements? And they would go through all of those in those conversations. And as I say, still with the ability to come on and carry out inspections, but not many inspections happening at all. So then we move on to the transitional regulatory approach. So this is fairly new. Having done the emergency support framework and sat back and thought, look, we'll just let you get on with what you're dealing with, they've realised that they've got to move forward. I think as August started to see some parts of the country opening up, then they're thinking, well, how are we going to progress this? What's going to be our regulatory approach going forward? And I think the key there is very much in the title. This is a transitional regulatory approach from the emergency support framework, transitioning to something different. So I think when we think about where we're going to end up with all of this, we are not going to end up back at the same point as we were pre-COVID in terms of the CQC's inspection regime. We're not going to end up back in the realms of routine inspections with great big long reports, and I'll come on to a bit of that later. So from the 6th of October, they have starting to roll out this transitional regulatory approach, starting with adult social care and dentists for some reason. And the key elements of that transitional approach are really that they are strengthening their ability and their data points for monitoring, increasing the focus from those 4 areas and from just infection prevention and control, for example, for trusts, to actually start looking back to the key lines of inquiry that we're familiar with: safe, well-led, effective, responsive, caring, and all the prompts that sit underneath those, but not going through every single prompt. What we've seen with adult social care so far is they have a list of the key lines of inquiry, particular focus on safe and well-led, but then taking some elements from the other areas such as effective, responsive, and caring. So a streamlined set of key line inquiries that will form the basis of their monitoring and focus during that time. No return to routine inspections during this transitional period. So fixed inspection timetables or frequency rules around if it requires improvement, they'll come back every 2 years. All of that's gone. No return to that at the moment. What will providers get following this transitional inspection? Well, you'll have a further conversation with them. This time the conversations again will be MS Teams, but it won't be lasting an hour. It'll be lasting an hour to 2 hours, according to the CQC. You'll then get a monitoring summary record of that conversation. That won't be published, but it'll be more meaty than the note of the conversation that I was referring to before in the emergency support framework. That will not be published. And also, because it's not a report, there'll be no factual accuracy process around that. I think all you'll get, if you've been subjected to that, I think all you'll get on the CQC's website is a very short statement that the CQC has reviewed you as part of the transitional regulatory approach and that everything is fine, or there are no concerns. It will be very straightforward, short statements, I would imagine. Still have the ability to carry out focused inspections where they identify risk and where that risk level demands that sort of inspection. But we're not talking about going into, say, 2 or 3 core services. We may just be talking about going into, if it's an A&E issue, just going into A&E. And if it's a particular focus point on A&E, just looking at that focus point, if it's medicines management, etc. So pretty focused inspections. What does all this mean for ratings and reports? The trouble that the CQC has is that the whole process of how they arrive at ratings and how they award ratings has been devised and is required to be devised as a result of public consultation. So they carried out a huge public consultation a while back, and they said, this is how we're going to do the ratings. They cannot change that without going through another public consultation. And no one's got time for that sort of a public consultation at the moment. I don't think we'll see that until next year, January, maybe through to March. So at the meantime, the rules around ratings stand. So a trust cannot have its ratings changed unless it has been subjected to a comprehensive inspection with a well-led inspection as well. And they're not going to happen. So what that means is that trusts' ratings are going to remain as they are. They're not going to shift. And for some trusts whose ratings may be based on inspections that have taken place 2 or maybe even 3 years ago, those ratings are going to start to feel a little bit old. And you might be fine with that if you've got good ratings, but actually that might be a source of frustration for a trust that was on the edge of good and is currently requires improvement, for example. I've started to see in the adult social care sector, a new sort of focused inspection around infection prevention and control. So the CQC have come up with 8 key areas on infection prevention and control. And actually the reports are starting to look like the old CQC reports before ratings, if anyone remembers those, where you used to get a green tick or a red cross. So there'll be 8 areas that they're looking at and judging compliance against. So how visitors are dealt with, how shielding is dealt with, how admissions are dealt with, what the use of PPE is like, testing, premises, staffing, policies. They've done 400 of these so far in the adult social care sector. And there is talk of that coming to a hospital setting, but we haven't seen any of that so far. So if we move on to what the future might look like, and I've touched on some of this, I do think we're seeing very much a move away from on-site inspections being the main focus of the CQC's approach. They want to work out how they can make better use of monitoring, better use of the intelligence that they get through, gather information outside of those physical inspection processes. So how do they gain the views of the service users? Can they do that through remote technology? And they're really focusing on that so that it isn't so much about these regular splurges of inspection frequencies. It's about something that's more dynamic and more risk-based. And potentially you've then got some access points and data points where actually you've got more of a live view, if you like, about the quality of what's going on in an organization, reflecting some of the data that's coming in. So I think any inspections that do take place will be much more focused. As I say, they will need a new approach to ratings. And I think we will see that at the start of next year, starting to think about what that might look like, because they will not be able to stick the ratings changes to those cases only where there's a comprehensive inspection. They'll have to come up with something more flexible. They've just published their draft discussion strategy, which sort of trails some of those issues in terms of what they want to do going forward. And they talk about this move away from periodic inspections. They talk about being a lot more smart in terms of the data that they make available to service users. They talk about accessing that information via an app as a member of the public. So there's quite a lot that's happening in that space that I do think once we come through that transitional approach, we'll end up with something that looks and feels very different. Senior figures in the CQC have been very clear that they very much want to move away from those long reports. They see that as something that of the past, really. And I'm not sure, they've sort of hinted about the change of ratings, and they've hinted at they want more focus on how people experience care rather than perhaps just a sort of blunt, is it safe or is it effective? Is it caring? I think they're trying to get something that means something to the service users. Shall we have a quick look at enforcement? There's been quite a lot in the news over the past couple of weeks about enforcement, and a few cases in particular highlighted. I think some of them have grabbed the attention of the press without necessarily the justification there. I think the Candor case is particularly interesting and worth looking at. Let's just deal with the first headline there. NHS hospital to face charges over a baby death in the first case of its kind. This is East Kent Hospital's University FT. They are facing, and they have faced, a prosecution under Regulation 12 of the CQC standards. That's the requirement to deliver safe care and treatment. This relates to the tragic death of Harry Richford at 1 week old. And the trust has admitted that there was failings in the maternity care, there was failings in the resuscitation of neonatal care, and they have admitted that there was a breach of Regulation 12, the failure to deliver safe care and treatment. It's the first acute hospital trust to face that prosecution. It's not the first trust. There have been mental health trusts that have faced prosecutions for breaches of fundamental standards, sometimes relating to the standards around the environment, safety of the environment of the hospital, but the sorts of fines that we've already seen in that space are fines of around 80,000. We've seen 200,000, 125,000. So I think actually, given that that trust has admitted that offence, we're not going to see a criminal trial with all the ins and outs of that case discussed. It'll move to sentencing, and probably move to sentencing quite quickly, when they will receive a fine, probably around about that sort of sum. But watch this space for that. Plymouth was a trust that has been prosecuted under Regulation 20 for breach of the duty of candour. Again, first prosecution of its kind. Well, yes, it's the first case that's is going to go to a judge to decide the sentencing, but there have been other cases. Bradford, I think, were fined, given a fixed penalty notice for breaching of the duty of candour. So there are other cases out there. And again, and I think this is fairly consistent with the way the standards are drafted. If you're in a difficult case, such as a failure to provide safe care and treatment, or you just haven't given the right apology in terms of candour, most of those cases will be admitted by the organisations concerned. It's very difficult to defend a case like that. You will only be able to defend it if you can show that you took all reasonable steps to prevent that offence from being committed. And in the Plymouth case, there was nothing wrong with their SI policy, and that was all. The court, the CQC was satisfied with that. What happened is there was a patient had a perforated esophagus during an endoscopy procedure. This is all the way back in December 17. Recognised complication of that procedure, and what that meant is that, well, the patient was the procedure was then abandoned. Patient went back to the ward. Unfortunately, the patient deteriorated and died. But because it was a recognised complication, the trust and the people involved did not recognise that as a serious incident. It wasn't classed as a serious incident under their policy. And what that meant is that then didn't trigger into the candour requirements. Because it didn't go down the SI route, people weren't then asking the questions around candour. So the trust in that case has admitted that it should have followed the proper candour route. It doesn't matter that it's a recognised complication. Those cases are caught by candour, and that often causes quite a lot of debate. Certainly when I give candour sessions and deliver candour sessions to surgeons, it causes a lot of debate. But recognised complications are caught by the duty of candour if the harm threshold is met. So if it causes moderate harm and above. The trust has admitted that offence. They were fined £1,600. They had to pay the CQC's costs of £10,000. And that trust has looked at its SI policy and has redrafted that so that recognised complications, if they're being discussed and recognised sort of post-incident, they would go down an SI route and would go down a candour route. I mean, I think there's a distinction there. Not all SIs necessarily have to be candour cases. And that's the difficulty, I think. There's a gap potentially when you attach your candour cases to your SI policy. So it's worth looking at how the obligations around candour match with the obligations around SIs, and if there's any gaps there, such as the Plymouth Trust found, trying to fill those gaps. This part in the middle is effectively it's exactly the title that you receive in a letter if you receive a Section 31 letter from the CQC. And in terms of trends, we've seen quite a lot of these sorts of letters being received by chief execs over the past 6 months. What this represents is that, let's remember, the CQC has very significant enforcement powers should it want to exercise them. It could, in theory, cancel a provider's registration without giving any notice whatsoever. It can impose urgent conditions on a provider's registration as well. It started to adopt the approach of writing to organisations and saying, look, we're very concerned about what we've seen. We are thinking about imposing urgent conditions upon your registration. Please tell us why we shouldn't, effectively within 24 hours. So these sorts of letters land on chief exec's desk, and then you've got a very limited amount of time to respond to that, with a view to trying to stop the CQC from actually taking that urgent enforcement action. So it's a sort of warning that they're thinking about taking a certain step. They haven't actually taken the step. And I think the CQC have been using that a lot over the last 6 months, to where they're really concerned about something, to make providers sit up and take action and produce action plans very quickly, so they can satisfy the CQC that actually these risks are known about and the trust does have a grip on them. So we've seen that happen quite a bit, and it requires quite a lot of running around to make sure that you're able to give the correct level of assurance to the CQC. Okay, that's all I was going to say on enforcement. If there's any questions, we can pick that all up at the end. I'll hand over to Georgia for a quick update on inquests.
Hi everyone. Yeah, so I've just got a very brief slot today because a much more detailed inquest slot was given at the last one of these sessions, which was at the end of July. So I'm literally just going to do, excuse me, a canter through of the kind of issues that our clients have been contacting us about over the past few weeks. But I mean, really, the position that most of the courts in the London area and the South East are in at the moment is that the vast majority do now seem to be listing a number of cases. There does seem to be quite a difference between the inner London courts, who are hearing a lot of cases remotely, well, partially remotely. So with the coroner in court and pretty much all witnesses and all legal representatives attending via video link. In contrast, the kind of outer London courts and just more widely in the southeast seem to be requiring people to attend in person. And so, it is very much down to the individual coroners. It is also down to the availability of appropriate technology, which usually is provided by the local authority. So there is quite a lot of variation at the moment. And I mean, generally clients and clinicians have been taking well, actually, to giving evidence remotely. Often for clinicians, it means that they don't have to necessarily take the entire day out of their clinical practice to attend a hearing. They can more easily slot it into, slot giving evidence into, something else that they might be doing in the day. And so it does work quite well like that. But some issues that we've experienced and we've been having calls about over the past few weeks is that for those courts which are insisting on in-person attendance, is that as the number of coronavirus cases is creeping up with the additional winter pressures anyway, clinicians may have less time, excuse me, to attend court in person. And some coroners are being more flexible than others with regard to remote attendance. Clients have also raised the issues around infection, both of attending court and also travelling to court, particularly in London. Some clinicians may have a 2-hour round trip to get to court, which obviously presents unnecessary infection risks. So, I mean, things to bear in mind if you're faced with these issues, particularly around coroners insisting on in-person attendance, are the kind of 2 chief coroners guidance notes which deal with this issue. So the first is number 38, which is about remote participation. And the chief coroner's view expressed in that is that partially remote hearings should take place wherever possible. Of course, this doesn't inhibit the use of physical courtrooms as long as they're in line with social distancing. But you can see from that the chief coroner's view, at least, is that where possible, coroners should be hearing these cases remotely. Guidance 39, paragraph 13, goes a little further and maybe of even more assistance. And it states, wherever possible, the evidence of key workers should be given via video link. And so that's something that, we have been referring to, particularly in cases where we've had 6 witnesses all called to court, and particularly in the last few weeks where pressures have been increasing. We have been instructed to make submissions that they shouldn't need to attend in person. As I say, the approach is very different across the region, to the extent that although the chief coroner's guidance is that partially remote hearings are generally not suitable, save in exceptional and limited circumstances, are the words that he used. We have had a 6-week jury inquest held by Southwark, which just concluded last week. In that case, there were 40+ witnesses, there were 7 IPs, and the entire thing, apart from counsel being present in court and the odd witness, the entire thing was held remotely. So the odd jury inquest is going on, but I'd suggest that the vast majority of coroners won't be listing many jury inquests. So I wouldn't expect that you'll see those unless you're in a jurisdiction where they have the availability of very large rooms so that there's space for socially distanced jury inquests. So, I mean, that's kind of like a canter through of what we've been sort of dealing with over the past few weeks. Things are really ramping up, certainly. We've noticed a huge number of short notice listings. The other thing to mention, just by way of update, is that the Morn case, which you may recall, is looking at whether the civil standard of proof should apply to the short form conclusion of suicide. The Supreme Court heard that case in February, but we understand that the judgment isn't likely to be available until early in the new year. So we're looking at kind of nearly a year really after the actual hearing. But that's just, so that's not looking as though it's going to be on the horizon anytime very soon. And then finally, just a quick mention about the Justice Select Committee, which is looking at the coroner's service. And the intention of it really is to kind of review how things have progressed and hopefully improved since the implementation of the 2009 Act in 2013. I hope that some of you contributed to that, because it's of great assistance for the committees to receive feedback from those who are operating within the coroner system on a day-to-day basis. A similar exercise was carried out in 2015, and unfortunately the results were never ever released. Any report was never provided about that, but we're hoping that something will come of this one and may create some improvements in the system going forward, but we're not really expecting anything further on that by way of kind of substantive recommendations until well into the new year. So that's really everything from me. And so could I perhaps hand back to Rebecca to see if there are any questions?
Thanks, Georgia, and thank you to all of our panelists today. That brings us to the end of the presentations, but we do have some time left for Q&A. You can still submit questions now if you haven't done so yet and you would like to. Just go to the Q&A box and type your question in. We've had a couple of questions through in the chat box. So the first question: should NHS Resolution run an early notification scheme for delayed diagnosis of cancer so they can capture early data and potential value and impact on NHS trusts due to the COVID pandemic? Really good question. So early notification we've seen at the moment relating to birth injuries, brain damage baby cases in particular, where trusts can notify NHS Resolution before a claim ever comes in, where there has been a poor, unexpected and poor outcome for a baby. So that scheme's really quite well established now and has been running for some time. As far as I'm aware, there's nothing in the pipeline to have early notification of cancer, delayed cancer cases due to COVID from NHS Resolution. But what I would say in relation to capturing data, potential value and impact is that there is an enormous exercise going on behind the scenes where all of the panel firms are capturing data from their member trusts in relation to possible COVID-related claims activity, and that is all being brought together at NHS Resolution. So they do have a really good picture actually of what's happening in relation to potential COVID-related claims and expenditure across the NHS, and carefully are monitoring expenditure on that basis. So watch this space, and of course if anything new comes on the horizon in that respect, then we will be in touch and make sure that everybody is updated on that. Charlotte, I don't know if you had anything you wanted to add specifically to that question. I know you do a huge amount of work on our ENS portfolio at the moment.
I mean, I think it's a really good question, and it's a really interesting point. And I suppose part of it might be that we probably need to see perhaps a trickle through of some more claims, you know, formally laid out, to really understand and just then be able to funnel down exactly what would be needed as part of any new scheme. I think at the moment probably it would be a bit more of a guesswork, but it's absolutely, as you say, something that I'm sure NHS Resolution are very much have in mind.
Absolutely. We've got another question, and I think this one is probably for you, Georgia. How many COVID-related inquests are we actually seeing coming through at the moment?
So at the moment, there are some starting to trickle through. We had a pre-inquest review on a fairly high-profile one a couple of weeks ago, and so they are coming through, but at varying rates. Certainly in our region, there's only been a couple, and those obviously are the more simple ones that have actually reached the point of inquest. But what we are finding is that families are, in those larger cases, really trying to push the boundaries of the scope to try and, kind of include as much as they can within scope, so that the coroner is, due to look at whether the trust was complying with the coronavirus PPE guidance at the time. And some even, sort of trying to push it to look at what the national guidance was and whether it was appropriate. The Chief Coroner's guidance on this has been tempered slightly from what he said originally, but his guidance at the moment is that usually an inquest will not be the appropriate forum to look at kind of high-level governmental decisions around the provision of PPE and the provision of NHS services generally. So yeah, we're seeing them come through, not loads yet, but the ones we have seen, the families are trying to, kind of expand the scope as much as they can.
Great, thank you, Georgia. And one more question in relation to CQC enforcement action. So this one's definitely for you, Ian. What sort of successes have we had or seen in relation to dealing with CQC urgent enforcement notices?
Thank you. Yeah, the urgent notices that I was referring to, I think we've seen quite a lot of success, provided that the organisations respond to those promptly and recognise that the very fact they've received a letter threatening urgent action under the CQC's powers means that you are in at the deep end with the CQC. But if you can show that you're on top of the issues, that you recognise that the CQC is thinking about imposing conditions on your registration, we've helped a few trusts, for example, suggest possible voluntary measures, reporting measures that they would agree to with the CQC, and sort of basically respond and say, look, we know there's an issue. We already have an existing action plan on this. We are getting information at board level on a weekly basis about whatever it may be, and suggesting that they share that information voluntarily with the CQC. And then I think the CQC responds well to that, and provided that those voluntary reports are provided on the deadline at the regular intervals that have been suggested, then I think that's sometimes that can be enough to keep the CQC away from that urgent enforcement action, because in part, what the sorts of conditions they would be thinking about would probably be forcing that reporting on a regular basis anyway. So if you can offer them something along those lines on a voluntary basis, then I think the CQC will end up thinking, actually, there's no point imposing conditions on this, but they will also want to keep quite a close eye on trusts. So we've had quite a few threats of urgent conditions, but I haven't seen any actually being followed through as a result of us supporting clients and helping them with that response.
Excellent, that's good news. I think that is it. I'll have a quite quick last check of the Q&A box. I think, no, we've dealt with all of the questions. So I think that wraps things up for today. If you do have any questions that we haven't dealt with today, or if you go away and have a think about it and there's anything you want to ask, then do feel free to get in touch with any one of us. Our contact details are there on this last slide, so it's always good to hear from people. And yeah, just look out for the follow-up email, which will have the link to this talk, which you're more than welcome to share with colleagues, and also that feedback form. So it would be lovely to get your feedback and any suggestions you may have for what you would like to see covered in future sessions. So thanks very much for joining us, and hope you all have a good rest of the week.